Yeah.
A very good evening, everyone. Welcome to iFocus Online, Lecture 267, Uvea Module number 8. Today we have with us Dr. Arshee Ahmed from Nethralaya, Chennai, talking to us on complications of uveitis. I invite Amod Gupta, sir, who's the panelist for today, to introduce her to our audience.
Well, friends, it's a pleasure to invite Dr. Arshee Ahmed from Nethralaya, Chennai, who's going to be talking on complications of uveitis. She has been a fellow earlier of uveitis and medical retina a long time back at Nethralaya, Chennai, and she was also the best outgoing fellow. And she is currently a consultant in the ever-expanding uveitis and intraocular inflammation group at Nethralaya, Chennai. And we are all looking forward to listen to you, Dr. Arshee. Please go ahead.
Yes, sir. Thank you, sir. Can I share my screen now?
Yes, ma'am.
So a very good evening to all of you. I would like to thank Dr. Amod Gupta for kindly introducing me and the amazing program which has been going on under the Uvea module as the iFocus program. It has been so fascinating to listen to everyone and refresh everything all over again. So I'm very thankful to all of you, all the organizers, for putting together this program. And tonight, I want to bring to you the various complications which one can encounter in a patient with uveitis. It is a chronic disease, and complications along the way are expected in most of these patients. And some could be disease-related, some could be treatment-induced. Timely diagnosis and management remain the key to prevent devastating vision-threatening complications in these patients. So today we will discuss all the complications which we can encounter beginning from the anterior to the posterior segment of the eye. So before we get into the nitty-gritty, just to refresh your memories, what is the SUN classification? That is the standardization of uveitis nomenclature classification, which was put together by the uveitis societies worldwide in 2004-2005. And what they did is basically tell us how to define or how to anatomically classify it based on the primary site of involvement. So it is quite straightforward. If the anterior part of the uveal tract, which includes the iris and the anterior ciliary body, is involved, it is anterior uveitis. If the vitreous is the primary site of inflammation, it is intermediate uveitis. Whereas if the posterior uveal tract, like the choroid, or the surrounding structures like the retina or the optic nerve are involved, it could be posterior uveitis. Special mention for scleritis and retinal vasculitis, which also we treat as uveitis specialists. So to put together today the various complications beginning from the sclera and as we go back, so this is what we will try to cover today in whatever time we can manage. So first is moving to the sclera. So the sclera, as we all know, is the outer 5/6 of the eyeball coat, and it is basically composed of irregularly arranged collagen bundles. It has got a rich nerve supply, but is essentially avascular primarily and derives its blood supply from either the episcleral tissue overlying or the underlying uveal tissue. Because it is richly supplied in nerve fibers, scleritis is usually a very painful condition. So what would happen when you get recurrent scleritis? When there is recurrent scleritis, the overlying sclera starts thinning over a period of time. The underlying uveal tissue would become visible, and it gives rise to this classic bluish hue which we see in these patients over a period of time. This can eventually result in ectasias and staphylomas, and if it is very severe thinning, it can ultimately perforate the globe. What are the other complications you can see or encounter in a patient with scleritis? They can develop anterior uveitis. The adjacent cornea also can start showing changes like peripheral ulcerative keratitis or even interstitial keratitis, maybe as a result of the underlying autoimmune condition which the patient already has. Uveal effusion can be seen if the location of the scleritis is equatorial. In patients with posterior scleritis, you will see complications in the posterior segment of the eye, like optic disc edema, choroidal folds, exudative detachments, and CME. Vision loss is a grave threat in these patients because of secondary glaucoma, cataract, and sometimes as a threat to the integrity of the eyeball itself. Now, how will we manage these patients? It is very important that you aggressively manage the inflammation from the beginning, of course, after making a proper etiological diagnosis. So either corticosteroids or immunosuppressives as is dictated by the diagnosis, or sometimes even if it is infectious, the appropriate anti-infective agent may need to be started. If it ultimately reaches a point where perforation is imminent, we take the help of our cornea team and they come up with these scleral patch grafts and amniotic membrane transplants for impending scleral perforations. As you can see in this photograph, this is a photograph of a young female patient who had chronic scleritis because of underlying rheumatoid arthritis of childhood origin. She did well after this patch graft was done. So next is moving to the next structure, that is we come to the cornea now. So the cornea is the transparent avascular structure which forms the anterior 1/6 of the eyeball. So the cornea, as we know, is avascular, highly transparent, and one of the first structures in the eyeball where the eye refracts. So any abnormality in the corneal tissue secondary to uveitis will definitely affect vision. The cornea does stare to bear the brunt in many acute and chronic uveitic conditions. So these are the complications which can happen. So in the first two photographs here, which I have put together, these are the two eyes of the same patient who had chronic viral keratitis, to be specific CMV anterior uveitis. You can see the large amount of corneal scarring which has happened in this patient in this eye, and the other eye shows active keratitis. We can also see peripheral neovascularization, or I should say vascularization, setting in. So vascularization can occur in many uveitic conditions in the cornea, and this is because of invasion of the blood vessels from the limbus into the corneal structure. Now, as blood vessels are normally not a part of the normal anatomy of cornea, this is an abnormal process. It is going to lead to lipid exudation, inflammation, scarring of the cornea. Rarely even perforation of the cornea can happen if there is severe thinning, as you can see in this patient. So this was an interesting case of a patient with HLA-B27 uveitis. This eye went into hypotony, and then this patient suddenly came once with a fungal corneal ulcer and a perforation in this eye. So other complications which can happen are decompensation of the corneal endothelium, especially in patients post CMV anterior uveitis. Band-shaped keratopathy is an important complication, especially in patients with childhood onset uveitis. First, it was described by Dixon and Bowman. So what is happening here is that there is deposition of calcium in the superficial layers of the cornea, especially the Bowman's layer, and the epithelial basement membrane and superficial stroma. So clinically, how do you see it? It will be visible as these grayish-white deposits starting at the interpalpable area near the limbus. These can then slowly cover up and start migrating towards the center, towards the visual axis, and then they can definitely impact vision. The classical Swiss cheese pattern is seen here. Another important thing to keep in mind is that these deposits do not reach the limbus. There is a lucid interval there which can help you differentiate. Why that interval is there? Because the Bowman's layer, where these deposits happen, gets terminated much before the limbus itself. That is why that lucid interval is present. So now, how do you deal with band-shaped keratopathy? EDTA chelation definitely helps. These are the photographs of, again, a young patient, female patient with JIA-associated uveitis. Although the uveitis itself was inactive, you see that massive band-shaped keratopathy in the photograph on the top. And post-EDTA chelation, the patient had very good recovery of vision. You see an almost entirely clear visual axis. So now next is moving to the iris. So iris, as you can say that it is in the hot seat of so many of the complications in uveitis patients. So what is the iris? It is basically a vascular diaphragm. So this is the iris, and as you can see, it divides the space in front of the lens into either the anterior chamber or the posterior chamber. So this normally is not in contact with the anterior lens surface. There is minimal space over there. And another important thing to bear in mind is the blood aqueous barrier, which is formed by the capillaries in the iris and in the ciliary body. So when a breakdown of the blood aqueous barrier happens, complications start developing. Various complications like, for example, defects or atrophy in the iris substance. Why does that happen? As inflammation progresses, the stroma starts getting replaced by fibrous tissue. So it will be visible to you as these atrophic defects. Now, atrophic defects can be seen in many conditions. It could be iatrogenic, like in surgical manipulation. It can be seen in patients with chronic anterior uveitis. Viral causes, especially like herpes zoster, would cause this kind of a sectoral atrophy. What is transillumination defect? Again, which are commonly seen whenever there is loss of pigment from the iris structure, as would happen or is expected in a chronically inflamed eye. The pigment is lost. So when you do a retroillumination on your slit lamp examination, you see all the light from the fundus being reflected back through these defects in the iris substance. And these are called as transillumination defects. So when you see them in a particular position or orientation, sometimes it gives a clue as to the diagnosis. If you see these defects in the mid periphery, maybe due to pseudoexfoliation or because of pigment dispersion syndrome in a normal eye. But these can also happen in a chronically inflamed or a chronically uveitic or chronic uveitis, especially like Fuchs heterochromic iridocyclitis and even in viral iridocyclitis. Rubeosis iridis, that is neovascularization of the iris. So that is again not a very good sight to see in a patient with uveitis. Usually it would happen in response to retinal ischemia. So what is happening is that there is a dysregulation of angiogenic factors. So the pro-angiogenic factors take over, lead to formation of these fine friable blood vessels on the surface of the iris. And these can then progress towards the angle and produce neovascular glaucoma in the later stages. Usually you can pick it up clinically on a slit lamp examination with high magnification, but when in doubt, iris fluorescein angiography will definitely aid in picking up these leaky new vessels. So now the pupil, what is the pupil? Essentially, it is basically an aperture in the iris diaphragm. So why is this important? Because the pupillary abnormalities, especially the structural abnormalities, are important in understanding secondary issues like glaucoma, which can develop in these patients with chronic uveitis. So now what is posterior synechia? So normally, as we discussed, the iris is not in real contact with the anterior lens surface. So any sort of adhesion which forms there between the iris and the structure posterior to it is a posterior synechia. So normally it would be the anterior lens surface. It could also be the intraocular lens if it is a pseudophakic eye. So here we see in this photograph this segmental posterior synechia which has formed, and the reason for formation is that there is breakdown of the blood aqueous barrier resulting in lot of cellular proliferation, high protein content in the aqueous, which leads to the formation of these fibrinous adhesions. Now these segmental fine posterior synechia can be relieved by the use of cycloplegic mydriatic agents, and if they are persistent or stuck, bound down, you can also during surgery lyse them easily with spatulas. So that was about the posterior synechia. Now what is a anterior synechia? So what is present anterior to the iris? Either it would be the corneal endothelium in the periphery, or it would be the angle structures near it. So any adhesion which is forming between the iris and the trabecular meshwork or between the iris and the cornea is called as a peripheral anterior synechia. These are very important structures which should be picked up in gonioscopy in uveitis patients, because once it reaches a critical level, for example, if more than 270 degrees of the angle is covered by these anterior synechia, it would result in symptoms. And then you have to look at other options, give other ways for the aqueous humor to flow. So this is how the normal aqueous drainage would be. So we see that aqueous humor is normally produced here in this region by the ciliary processes. Once it is secreted, it would flow over the anterior lens surface, that is the posterior chamber, through the pupil come into the anterior chamber, and then it drains out from here through the trabecular meshwork or through the uveoscleral outflow. So this is how the normal aqueous physiology works. Why that is important is so that you can put into perspective what is happening in an abnormal situation like this. So now imagine a eye having 360 degrees posterior synechia, that is called as ring synechia or the annular synechia. Now when the entire surface of the iris has got stuck down to the pupil, there is no way for the aqueous to flow. It is still being produced by the ciliary processes, still collecting here in the posterior chamber, but unable to come out into the anterior chamber. So this will now cause a bowing of the peripheral iris forwards. So okay, a little bit of bowing may be tolerable, but then when it keeps on collecting there, this peripheral iris is going to go and block the angle. So this is called as a positional angle closure. That is because of the peripheral iris bowing forwards. And this would now result in increased intraocular pressure because there is no way for the aqueous in the anterior chamber also to flow out. So this condition is clinically called as iris Bombay. So as I mentioned, it is because of the formation of ring synechae, or seclusio pupillae is the term we use. On clinical examination, you will pick it up as this anterior bowing of the peripheral iris. You see that there is hardly any space between the cornea and the iris in the periphery. The angles are closed. Intraocular pressure is high. So how do you relieve this? You need to make an alternate pathway. So the help of peripheral iridotomies, that is laser PIs, you can make a hole in the peripheral iris and allow for the aqueous humor to be able to move again. The other problem here is that in patients with uveitis, this is not a normal quiet eye. These PIs will tend to get blocked repeatedly. And as they get blocked repeatedly, each time you have these episodes of high intraocular pressure, which increase the chances of optic nerve damage with each episode. Sometimes these patients may need surgical PIs to prevent repeated blockage. Now, another condition is occlusio pupillae. So unlike seclusio pupillae, here you see a very deep anterior chamber. So why do you see a deep anterior chamber? That is because the entire iris surface has gone back and got stuck to the anterior surface of the lens. So it becomes a totally deep anterior chamber. Usually we see this in patients towards the end, probably when hypotony is setting in. So, but this is an important clinical sign to pick up in these patients. Ectropion uveae, on the other hand, is a term which we use when you see this brown pigment on the pupillary margin. So what is that pigment? Where is that coming from? It is basically, there is traction. The fibrovascular membranes, due to inflammation, contract. They pull the posterior pigment layer to the anterior surface of the pupil, essentially an eversion of the pupillary margin. This is ectropion uveae. We can see it many times in chronically inflamed eyes. Now moving to the next structure, the important structure, that is the lens, which is essentially dividing the eye into the anterior anterior segment and the posterior segment. So the lens it's a transparent avascular, again a highly refractive structure, and lenticular opacities are called as cataracts. So the most important complication the lens can show us in a uveitis patient would be the development of cataracts. Now, either it can develop because of chronic inflammation itself, or it could be treatment induced, especially steroid induced. So both of these issues are issues which can lead to rapid visual decline sometimes. So this photograph, we see a patient with Fuchs heterochromic iridocyclitis, a young patient who presented with, suddenly he noticed absolute loss of vision in one eye. And when you see the patient, it is a Fuchs heterochromic iridocyclitis with a total cataract. And this is the photograph of a patient of HLA-B27 associated anterior uveitis. The patient was using steroid drops injudiciously. Every time there is any episode of redness, the patient is using steroid drops to get relief from the inflammation, and you would develop something like this with a polychromatic luster or a breadcrumb appearance described classically for steroid-induced cataracts. Now, any cataract is visually significant, but in a uveitis patient, it is all the more challenging. Surgery is more complex because you have other issues associated, like posterior synechae. It may be already a glaucomatous eye, or there even may be early hypotony setting in. So meticulous planning for removal of these opacities is important. So management of uveitic cataracts is a very important and important issue to maintain quiescence of inflammation as well. Because if we go on and operate in an inflamed eye, rather than helping, we are actually causing worsening of the inflammation. So what is the indication to operate? First is if it's a visually significant cataract, and if it is precluding a view or examination of the posterior segment, we are justified in removing it. As much as possible, as far as possible, we need to try to evaluate the posterior segment before you take up these eyes for surgery. The patient may already be having cystoid macular edema. There may already be significant vitritis. All that is going to affect your visual outcome. So as far as possible, have a thorough examination done first and then plan to take up the patient for surgery. Good perioperative control, which includes good preoperative and good postoperative control, is very essential. Guidelines say that at least 3 months of quiescence is important to prevent recurrences of inflammation. So how do we attain that? Is giving a good cover of topical steroids or non-steroidal agents as indicated. Give the patient a good cover of oral steroid therapy. Immunosuppressive therapy should ideally be continued if you're planning to take up the patient for surgery. What is the choice of procedure? Do a good phacoemulsification with in-the-bag IOL implantation. So that is important because if you end up implanting the lens in the ciliary sulcus, it is going to just worsen the situation because the constant rubbing of the haptic and the ciliary body will give rise to a chronically inflamed eye. So usually we prefer for hydrophilic acrylic IOLs. Another important thing is aim for a larger rhexis as compared to a normal eye because these eyes are at high risk of developing capsular phimosis. Now, once you have done the surgery, there are still IOL related issues which can develop in these patients. You may develop a lot of IOL deposits. Synechia can form between the iris and the IOL. Capsular phimosis is a possibility, posterior capsular opacifications, and rarely in chronic conditions, because of zonular weakness, you can develop IOL subluxations and IOL drop. Now moving to the next structure, that is the vitreous. So the vitreous is one of the largest structures per se in the eyeball, occupies almost 2/3 of its volume, and it's around 4 ml if you can get to measure it. So the vitreous is basically bounded anteriorly. You have the posterior part of the lens and the retrozonular part of the ciliary body. So these form the anterior boundaries of the vitreous. It is basically composed of a dilute meshwork of collagen and hyaluronic acid. Now, vitreous is primarily involved in patients with intermediate uveitis, where the setting of the inflammation is in that particular part of the eye. So what are the complications you can come across? You can see multiple exudates, that is basically condensation of the inflammatory material. The vitreous can, over a period of time, start opacifying, especially in patients with pars planitis. Even in toxoplasma retinitis, you may see an opacified vitreous. Vitreous hemorrhage can definitely happen if there is any kind of a proliferative retinal stimuli going on. And in this photograph, as you see, extensive membranes, extensive exudation inferiorly. So when these membranes are covering the pars plana and decide to undergo traction over a period of time, these can result in peripheral tractional detachments. So on similar lines, just a brief word on what is a cyclitic membrane. So it's basically a retrolental fibrovascular tissue. It will extend from the ciliary body across the pupil or the anterior face of the vitreous. So why is this important? Of course, it can obstruct vision, but more importantly, when this membrane contracts, it is going to pull your peripheral retina. It is going to pull the ciliary body, which will result either in a retinal detachment or hypotony. So just a brief word on pars plana vitrectomy, because that would sometimes be the treatment of choice in these patients after you have exhausted all your other medical therapies. So it can be either diagnostic or even therapeutic in eyes with chronic vitritis or especially like opacified vitreous. It helps us in debriding and debulking the vitreous. So it aids in basically a therapeutic clearing of the media. You can also obtain samples for further testing, like for cultures or stains, cytology, and even PCR studies to aid in diagnosis when there is a diagnostic dilemma. For example, if there is an atypical chorioretinitis, or you're suspecting intraocular lymphoma or other chronic ocular infections. So when you're doing this, it is important to keep in mind that you need an undiluted vitreous sample to be sent for testing. Next is moving to the macula. So the macula is basically essentially derived from macula lutea, that is the yellow spot. So this is essentially the part of the retina which is serving the central 15 degrees of your visual field. And in that, the central 5 degrees is the fovea. So these days, with the advent of all the newer ancillary diagnostic techniques like OCT, it has become very easy to be able to delineate structurally all the layers of the macula. So macula is one of the thickest layers of the retina, surrounding one of the thinnest layers of the retina, that is the fovea. So what are the most common complications which you would come across in the macula in patients with uveitis? So first is cystoid macular edema. So this is one of the most common causes of visual loss in uveitis patients, and many studies show that maybe 30 to 40% of chronic uveitis patients would develop CME at some point or the other. So why do we get macular edema? So to go back to its origin, what is happening here is that there is a disruption in the blood retinal barriers. It has, I think, already been covered, but as you know, there is an inner blood retinal barrier, there is an outer blood retinal barrier. So the inner blood retinal barrier is very similar to your blood aqueous barrier because it is formed by these tight junctions in the capillaries, the retinal capillaries. Between the two cells, you have these tight junctions. And at the RPE is the outer retinal barrier. So both will work and try to maintain the retinal structure as compact as possible in a state of detergescence, that is, there is no fluid there. But whenever there is a disruption here in these barriers, or there is Muller cell damage. Now, Muller cells are these supportive cells which are running through the retina. So any of these processes will lead to accumulation of intracellular fluid. Where is it happening? Where is it most likely to happen is in the outer plexiform and the inner nuclear layers. And that is why this gives rise to that cystoid appearance of the macula. So as you obviously understand that what is happening here is again a dysregulation. So the pro-inflammatory mediators go up, the levels go up in the vitreous. Also, if you're able to check it, mediators like VEGF, interleukin 6 are very commonly implicated in development of macular edema. So although macular edema is not very commonly seen in anterior uveitis patients, you see it very commonly in patients with intermediate and posterior uveitis. So how do you detect it? Clinically, you can detect it on the indirect or even on the slit lamp examination with the appropriate 78D or the 90D lenses. You will see these typical cystoid spaces. But even before you reach this point, the patient's history will sometimes give you a clue. A patient with uveitis doing well may suddenly present to you with complaints of reduced near vision, reduced reading speed, reduced contrast sensitivity. So these are all signs and symptoms of macular involvement. So in this patient, you can see the cystoid spaces. This is a patient with intermediate uveitis. So although clinically you can pick it up, but sometimes it may be very early to pick up clinically. We definitely rely on ancillary investigations like OCT and FFA to pick up cystoid macular edema. So as you can see here, the normal foveal contour is lost. You see an elevation. You see all these empty black spaces, hyporeflective spaces. This is where actually the fluid has collected. Now on OCT, it can be various patterns you may see. It could be just a diffuse thickening of the retina. You may see these cystoid spaces, and even in this patient here, a very early neurosensory detachment where there is separation of the RPE and the neurosensory retina. So these are the different kinds of signs we can pick up on OCT examination. Fundus fluorescein angiography, of course, is also important because it is identifying breakdown of the blood retinal barriers. So when there is a breakdown, the dye will leak from these inflamed capillaries or through the RPE. And when it leaks around the macular capillaries, it collects in this classical flower petal kind of arrangement, which is called as the petaloid pattern. This is usually visible in the later phases of the angiogram. Other macular pathologies which you may see are epiretinal membranes. So what are epiretinal membranes? These are avascular fibrocellular membranes on the surface of the retina. Of course, because of long-standing inflammation, a lot of factors playing at the vitreoretinal interface, these membranes can develop. If they are thin, not causing any traction on the retina, they are usually asymptomatic. But they can produce metamorphopsia if there is any traction on the retina. Even in this OCT, we can see that the membrane is causing retinal thickening, and this patient did complain of metamorphopsia. So OCT is the investigation of choice definitely to monitor ERMs. Now in a patient with chronic macular edema untreated, if there is a de-roofing of the cystoid spaces, you can also develop macular holes, which will further contribute to visual decline. Now, next is moving to the retina. So the retina can, again, of course, develop various sorts of complications in patients with uveitis, especially more so when there is posterior uveitis. So first is speaking about retinal ischemia and neovascularization. So when there is impaired blood flow to the retina, or the blood supply to any particular part of the retina is obstructed, for example, in a patient with retinal vasculitis, that part of the retina would become hypoxic. This hypoxic retina is going to produce pro-angiogenic factors, again, like VEGF, which contributes to increased breakdown of the blood retinal barrier and leads to neovascularization. It could happen from the retina itself, or it could happen from the choroid posterior to it, which results in retinal and choroidal neovascularization. So this is the photograph of a patient who had a retinal vasculitis secondary to autoimmune causes and presented with sudden decline of vision. So here, as you see, the disc shows some amount of leakage. It's a hot disc. You see massive retinal capillary leakage. The vessels are staining, which is suggestive of inflammation in the retinal vessels. And you see this big dark area at the macula. There is no blood supply to that area. So you see these blood vessels devoid of any fluorescein there. So this is a capillary non-perfusion area. This is responsible for the massive vision loss in this patient. She had actually only hand movement vision in both the eyes. So similarly, as we have discussed about the neovascularization, we classify it based on its location. So it could be either neovascularization on the disc or neovascularization elsewhere, that is NVE. So what is NVD? When you have new vessels forming on the disc or within one disc diameter of the disc margin is NVD. NVE is when it develops anywhere else on the retina. So fluorescein angiography is definitely the investigation of choice to pick up neovascularization. And as in the previous case, and even in this case, in this photograph, you see enlargement of the foveal avascular zone, which are all signs of macular ischemia and poor visual outcome. Now, why are you able to pick up these vessels on fluorescein angiography? So normally the retinal and vessels would not leak any dye because the barriers are intact. But when there is any inflammation, these capillaries leak and the dye also leaks along with it. So you can easily pick it up on the fluorescein angiography. So when these vessels leak, similarly, they can also leak, as in they can bleed or hemorrhage. This will produce a vitreous hemorrhage. Over a period of time, fibrovascular changes will start developing, and these can start producing traction. This can also result in tractional retinal detachments in these patients. So here in this patient, as I was telling you, we see all these areas of capillary non-perfusion. We see development of neovascularization elsewhere, which are leaky, although it is a well ablated eye, but the process sometimes continues and then takes time to settle down. So this is another photograph of a patient with retinal vasculitis. So this is the optos photography, that is a wide field view of the fundus. You see a lot of vitreous hemorrhage here. We suspected the patient to have NVD, although the view was not very clear. So you rely on a fluorescein angiogram to assess better what is happening to the retinal blood vessels. So here we see, this is the early phase. You see some early leakage beginning at the disc. You see some more spots of leakage developing. You see all these vascular staining, some non-perfusion areas as well. So as the angiogram progresses, you can clearly identify the leaking new vessels on the disc and elsewhere. So this patient had both NVD and NVE, and you also see these peripheral CNP areas. So what are the conditions where you would commonly see this? Neovascularization we see very commonly in patients with intermediate uveitis, sarcoidosis, tuberculosis, especially TB vasculitis, and even in Behçet's disease. The capillary non-perfusion areas are again commonly seen in TB retinal vasculitis, Behçet's disease, patients with SLE, and even in herpetic necrotizing retinitis. And we can label these conditions as occlusive vasculitis. Now, similar to retinal neovascularization, the choroid can also start reacting to the chronic inflammation. So what would happen is, whenever there is a break in the Brooks membrane and the RPE, the new vessels, similar to the mechanism we saw earlier, the new vessels start growing. They may grow into the sub-RPE space or to the subretinal space, and that is how it is classified as either type 1 or type 2 CNVMs. Uveitic CNVMs are usually type 2, that is, they would grow into the subretinal space. Clinically, you can pick them up, like for example, in this patient has got a peripapillary CNVM, that is within 1 disc diameter of the optic nerve head. So you see this membrane here, and you also see this area of subretinal bleed next to it. Along far away, you see this exudation, this thin line, which is because of the fluid which has collected. So this patient will again present to you like in any other macular pathology with blurred vision, metamorphopsia. However, if the macula is not involved, it may go unnoticed. So it is very important to look out for these changes, especially like, for example, in a patient with VKH, the patient may not have any symptoms, but it is important to look for these choroidal neovascular membranes. So we can, along with our clinical examination, of course, you can also rely on other techniques like fluorescein angiography and OCTs. So here I have just put the photograph of a patient with a choroidal neovascular membrane. So this patient had chronic intermediate uveitis. So you see here the collection of intraretinal or subretinal fluid may be there. It can also sometimes bleed and cause a subretinal or a sub-RPE bleed. Of course, the important thing is to pick up the CNVM itself, which is visible as this highly reflective fibrovascular tissue. So either it can be type 1 or type 2, as I just told you. This is the photograph of the same patient I showed you earlier. So I've just marked it here. So this is the membrane and this is the subretinal heme. On angiography, you can quite easily pick up these membranes. So in the early stages, you will start seeing early hypofluorescence in the region of the membrane. And if you wonder what is this dark region, that is the subretinal heme, which is blocking the fluorescence, and that is why it's a blocked fluorescence. In the later stages, this membrane will show late leakage, classically lacy leakage, but sometimes we may not be able to pick it up because of massive diffusion of the dye. So this is how we can pick it up on an angiogram. Before I move to the next topic, the treatment, here most important thing is to also assess whether the patient has active inflammation, because this is not a CNVM developing secondary to ARMD. This is an inflamed eye. So just treating the neovascular membrane will probably not be the correct way to go about it. We need to understand why is this happening. So this is happening because of low grade subclinical inflammation. So it is important to also address that. We need to treat the inflammation also with appropriate corticosteroid therapy or immunosuppressive therapy. As an adjunct to that, local treatment can be offered to the patient. Anti-VEGF agents, rarely we may even require the use of photodynamic therapy to give local treatment to these patients to obtain a good visual outcome. Now, a very vision-threatening complication in these patients is retinal detachment. As you all know, retinal detachment is basically of 3 types. It could be rhegmatogenous, where it is happening because of a break in the retina. It could be tractional, and it could be exudative, where there is no traction, no break, but there is fluid which has caused separation of the neurosensory retina from the RPE. So when will you see rhegmatogenous RD in a uveitis patient? Most commonly post viral retinitis like CMV or VZV retinitis. Even in patients with toxoplasma retinal necrosis, they can develop rhegmatogenous detachments. Tractional RDs are most commonly seen in patients with chronic intermediate uveitis, especially in the periphery, with toxocara granulomas, and as we discussed earlier, cyclitic membranes many a times in patients with JIA associated uveitis because of the chronicity of the disease. Exudative detachments in patients with VKH, sympathetic ophthalmia, posterior scleritis, and panuveitis. So exudative detachments usually will be visible as this collection of fluid under the retina. It may also shift with a shift in the position of the patient. You can pick it up as, that is called as the shifting fluid sign. You can also document it on ultrasonography if you do the ultrasonogram in the lying down and in the sitting position. In the sitting position, due to gravity, the fluid will gravitate down and it will be picked up easily as a detachment. When you do an angiography in these patients, for example, in a VKH patient, you would see the classical pooling of the dye as the angiogram progresses. So a quick word on rhegmatogenous and tractional RDs. So rhegmatogenous RDs, the incidence has been given to be around 3% in patients with infectious uveitis and 2% in non-infectious uveitis. Usually it is a combined mechanism here. So it may be a combination of both a break and traction which is happening. So you see these pinpoint breaks in the periphery. You may not be able to pick it up on a clinical examination, but because of the traction, the breaks happen and then leads to detachment. So many a times it's a combined mechanism. Higher risk of detachments is seen in infectious retinitis and panuveitis patients. Although rhegmatogenous RD, because of viral retinitis, would have a poorer prognosis because these are large posterior breaks. These are usually more difficult to treat. Repair also is difficult in these patients because there could be pre-existing PVR, that is proliferative vitreoretinopathy. There could be an organized vitreous. There could be poor visualization because it could be an inflamed eye. So to summarize now, the role of pars plana vitrectomy in uveitis patients, these would be the probable indications: vitreous opacification, debris, hemorrhage, retained lens material, lens-induced uveitis, epiretinal membranes, cystoid macular edema, tractional and reg RDs, in patients with cyclitic membranes leading to hypotony, and in patients with uveitic glaucoma where you want to put a posterior tube placement. So the principle of repair even here in these uveitic eyes is the same as in a non-uveitic eye. You relieve the traction, seal the break, and attach the sensory retina back to the RPE. But an important word here, sometimes we may not be really able to prepare the eye for surgeries. It could be a surgical emergency, for example, in a patient with ARN. So at least aim for good perioperative control of inflammation to prevent complications like PVR and cyclitic membrane formation in the future. If the patient already has had retinal issues, the final visual outcome will definitely tend to be poorer because of various factors like scarring or retinal ischemia, retinal neovascularizations, and even retinal necrosis. Now, towards the end, one of the last structures which we will discuss is the optic nerve head per se. So the optic nerve head can respond to this inflamed eye in various ways. It can also show inflammation, which would be visible as a hyperemic or a reddish disc, along with formation of new vessels on the disc or an atrophic disc. So the hot disc is, as I showed you one of the angiograms earlier, whenever there is leakage of dye from the disc, it's called as a hot disc and is an important marker of inflammation. You can also use this sign as a prognostic marker during treatment. The other problems which you may see in a chronic uveitic eye is optic atrophy, and you can even see neovascularization on the surface of the disc. And last but not the least, these patients with uveitis can end in both extremes of intraocular pressure issues. So that could either be secondary glaucoma or it could be hypotony. So it's a vision threatening complication in these patients. The prevalence is known to be anywhere between 10 to 20%, but it can also be as high as up to maybe 45% in patients with chronic uveitis. It can happen in any sort of uveitis, secondary glaucoma, but the more common conditions like Fuchs heterochromic iridocyclitis or Posner-Schlossman syndrome, and even in patients with JIA associated uveitis, they are always at a higher risk of developing secondary glaucoma. So as we know that the IOP is essentially maintained, there's a delicate balance between its production and its outflow. So as we saw earlier when we went through the pupillary abnormalities and the iris abnormalities, glaucoma can happen either because of two mechanisms. It could be an open angle glaucoma or a closed angle glaucoma. Open angle glaucoma as a mechanism is more commonly seen as compared to closed angle. So why will you get open angle glaucoma? There could be hypersecretion of aqueous, blockage of the trabecular meshwork spaces. There could be inflammation of the trabecular meshwork itself, that is trabeculitis, or there is a damage to the meshwork, and even steroid-induced glaucomas. Closed angle, as we already covered, whenever you have the formation of posterior synechae, pupillary block, peripheral anterior synechae, and rarely a word here, like for example in patients with VKH, None of these may be the reason, but it could be a forward rotation of the ciliary body because of the inflammation, which can produce a close angle glaucoma. I think we have covered most of these things, so I'll just skip this. And a quick word on steroid-induced glaucoma. So steroids basically tend to produce a lot of biochemical and morphological changes in the trabecular meshwork. All of this leads to a decreased aqueous humor outflow and elevate the intraocular pressure. So the treatment for steroid-induced IOP rise would be to, first is logically to discontinue it. If you're not able to discontinue it, you can shift the patient to weaker steroids, which have less propensity to cause IOP rise, or shift to non-steroidal agents. If the patient has already received a posterior subtenon's injection, for example, if there's a deposteroid, you can try to excise it. But ultimately, any uveitic glaucoma patient would require either anti-glaucoma medication or filtration surgery like a trabeculectomy with the use of MMC, or again, a shaky outcome even there. Sometimes these patients end up requiring glaucoma drainage devices. So this is the photograph of a patient we had who had actually undergone lens placement, IOL placement elsewhere. And if you can see, the IOL is actually in the sulcus, and this has led to a chronically inflamed eye. The patient first underwent a trabeculectomy with MMC, which failed, and ultimately this patient required AGV with tube. Of course, with this, the pressures were okay, but secondary glaucoma is a very devastating complication, and we should try to avoid it at all possible costs. And as we near the end now, the other extreme of intraocular pressure issues is hypotony. So what is hypotony? When the pressure in the eye goes down. So probably for practical purposes, a pressure of less than 6 or 7, we would label it as hypotony. But if the pressures are less than 4, 5 chronically, it would lead to many dreaded complications, including shrinkage of the eye. So hypotony, it could be a reversible issue in the beginning. If it's suddenly an acute inflammation, the ciliary body reacts by reducing the production of aqueous. So that is an acute inflammation leading to a temporary hyposecretion. That is, classically we call it as a ciliary shock. But it can also be a chronic damage, which would then result in a permanent hypotony, or because of traction on the ciliary processes because of a cyclitic membrane, again leading to more permanent hypotony. Which patients are more prone to develop hypotony? When there is early onset uveitis, like childhood onset uveitis, or if it's a chronic uveitis, GIA associated disease, those patients who have had a chronic retinal detachment which has probably gone untreated, or many a times post vitreoretinal surgeries and even glaucoma surgeries, hypotony is a big threat. So we do attempt to treat it, although a frustrating experience many a times. Intensive use of topical steroids, local steroid like a posterior subtenon's injection. Ultimately, these patients may require vitrectomy, where if there's a cyclitic membrane, you can attempt peeling the membrane and then fill the eye up with silicone oil to probably maintain its anatomical integrity. So here just a few pictures on how a UBM would look like in a patient with hypotony. So this is one of our, again, HLA-B27 patients, and this eye was already going into early hypotony. So you see this large space here. This is a supraciliary effusion in between these, that is accumulation of fluid in the suprachoroidal space. You see this thick pars plana membranes. The ciliary processes itself are hardly, you can pick it up, they are almost atrophied. So all these are signs of ciliary shutdown. And now once the eye has gone into hypotony, ultimately this is end stage for the patient and for that eye. So it can either end up initially as an atrophic bulbi, where it's a small globe but the structures are still recognizable, or end up as a thicical eye, that is thysis bulbi. Again, a small globe, but when the structures are now unrecognizable, already intraocular ossification is setting in. So here we see this is a patient with a thicical eye. I've put this so that you can see that this high spike here on the ultrasonography, which corresponds to the calcium deposition, the early intraocular ossification. So the 4 S's, which are classically described as sightless, shrunken, shapeless, and soft. So these are classically, these would fit into the thysis bulbi. So just to now recapitulate before I end. So these are the various complications, and just as a takeaway message, I have just tried to put it as based on the classification. Of course, pan-uveitis patients can have all these complications. And just a small slide for you to keep in mind all the investigations which you need while evaluating a patient with uveitis, which will help you in picking up these complications and for prognostic purposes. Thanks a lot for your time and patience.
Thank you, Dr. Arshee, for the extensive talk and for systematically covering everything in complications from anterior to posterior segment. With Dr. Amod Gupta and Dr. JB sir's permission, I'll start the questions, sir.
Yeah, sure.
There are 4 questions. So the first question is, clinically in acute anterior uveitis, which subset of cases may develop hypotony secondary to ciliary shock versus increased IOP secondary to inflammation? So they basically want to ask which cases will develop hypotony and which cases will get increased IOP in acute anterior uveitis.
So may I take that?
Yeah, it's for you. Please.
Yeah, sir. Patients with anterior uveitis developing high IOP, especially if it is a viral cause, if you're suspecting a viral uveitis, these patients would tend to show you higher IOPs. Hypotony, initially, sometimes it could be idiopathic reasons, and if it is going into a chronic hypotony, it is probably a case with a childhood onset uveitis, like patients with JIE associated uveitis who have been having the disease for a long time. But essentially, otherwise, even conditions like Posner-Schlossman would present with a very, very high IOP, like in the range of 40 to 60. So viral causes, Posner-Schlossman syndrome, these are all causes of high IOP even in the beginning with anterior uveitis. So you would like to add anything, sir?
No, I think you, Arshee, covered the subject very, very comprehensively. And I don't think I can add anything significant to your discussion. If I say rule of thumb is that the pressure would be lower side in any acute uveitis and in chronic uveitis. But if there is a high pressure recorded, we think of a viral cause of uveitis. So I think we can put it that way. If there is an acute rise in pressure, we also think of in the setting of VKH syndrome, sometimes, because of the cilioparietal thickening, there's the forward rotation and angle closure. So that is also one situation where you would have a shallowing of the anterior chamber and a secondary kind of angle closure glaucoma. So these are the situations where you would have high pressure. But these are the ones where you need to have high index of suspicion for viral infections, as well as, for instance, like VKH disease.
Thank you, sir. Thank you, Dr. Arshee. The next question is, apart from a stable intraocular pressure on follow-up, what are the markers to know the patency of a PI? How do you know the patency of a PI? Dr. Arshee?
So to check the patency of the PI, a good clinical examination is required, along with the checking of the intraocular pressure. When you're seeing the patient on a slit lamp, you can always look for the patency of the PI. So when you do a retroillumination, make a small beam, shine it through the pupil, and look for that area to light up specifically. So then you will know that it is a patent PI. So clinically, that is how you would recognize it.
Thank you.
The first place you do a PI when you see an iris bombay. Now, if the iris bombay returns, that means your PI is closed down. And somebody who asked this question probably has had patience, because it's very difficult to have a patent PI or LI, in patients with inflamed iris. They tend to shut down. So you need to call the patient again after 2 to 3 days and revise the LI and try to expand the size of the opening and hope that it will not close down, because laser itself induces inflammation, already inflamed eye, and it tends to have some kind of fibrinous reaction around this site, and it sticks to the anterior surface of the lens. So this is a challenge, doing an iridotomy in patients with secondary glaucoma due to iris bombae.
Yes, sir. Thank you, sir. The next question is, if there is a total cataract with anterior chamber inflammation in acute uveitis, do we anticipate anterior vitritis as well in all these cases? When there's a total cataract with AC inflammation, do we always expect an anterior vitritis also?
It's good to suspect anterior plus, because anterior uveitis per se to cause total cataract is an unusual situation. Acute hydration can take place if there is a posterior capsule rupture in these patients. Sometimes dehiscence of the capsule can cause acute hydration and acute cataract, but otherwise mostly it will start as a posterior subcapsular cataract. So because you want to do surgery, so these are the kind of patients where you would put them on systemic steroids with the anticipation that possibly there is an inflammation in the vitreous cavity. And you might like to do an ultrasound examination to make sure, because it will pick up, if there is any associated retinal detachment or, posterior choroidal thickening or a VKI syndrome or stuff like that. So if there's no view of the retina, you must do an ultrasound examination in these patients.
Yes, that's a very important point, ultrasound. Now the last question, what are the precautions to be considered while operating on a complicated cataract in uveitic patients? This is a very long question.
Yeah.
Who would like to come, Dr. Arshee? Okay.
So as I did try to cover that, but as you said correctly, it's a topic which requires another hour of discussion. So of course, aim for a very good preoperative control of inflammation. That is the most essential thing. During surgery itself, there are so many things you can keep in mind. Minimal manipulation of the structures in the iris. Do a good sized rhexis. Aim for in the bag IOL placement. Aim for a thorough wash of the cortical fibers to prevent early PCO formation. So these are things during surgery you would keep in mind. And at the end, aim for an in the bag IOL implantation. To be very concise, I think. Sir, would you like to add anything?
Yeah, pre-op control of inflammation is very, very critical, because these eyes don't tolerate cataract surgery very much if there is any inflammation in the eye. So one has to control that by any means. You can use peroperative or intraoperative dexamethasone implant, or you can use intravitreal triamcinolone acetonide, to minimize post-op inflammation, because that will remain an issue. These patients also tend to have, earlier posterior capsular opacification. So you might like to do a primary posterior capsulotomy if you are putting an intraocular lens implant. As you rightly said, it has to be put in the bag, capsular rhexis and in the bag implant. So, and you might like to add a little bit of posterior capsulotomy, primary capsulotomy, as well as do a little bit of anterior vitrectomy through the capsular opening, because these patients, they tend to develop these retrolenticular membranes, fibrous membranes, which not only cause posterior capsular opacification, but also the fibrous membrane may grow, and the anterior vitreous provides that scaffold for the migrating fibroblasts. So if you do that little bit of, particularly in children, you have to do this kind of exercise, to prevent the opacifications. Then these patients, need long post-op care, because it might look good for a few days or few weeks or even months, but years later, there is a contraction of the capsular bag, and contraction of the capsular bag may push the lens out of the bag. So that also is a known complication. You'll be surprised to see how much the bag can contract and push the lens out of the bag, and it might come to lie, one or both haptics might come to lie in the anterior chamber. So for that one reason, specifically, we face this situation when you're operating in young children in GIA-associated complicated cataracts. Personally, I was, not very happy with putting an implant in these eyes. And invariably, they ended up in long-term complications are very high in these children. So the jury is still out. People have their own experiences world over where they can control inflammation maybe better than we can control here in our settings, the compliance issues and others. But I was not very happy with putting an implant. I would rather have a patient wear take glasses or contact lens for correction, if she did a good partial lensectomy and cleared the entire crystalline lens, So I would be very happy with that. But, people do put implants and they report happy results, but nobody has reported long-term results. What happens to the implant? Remember, we are putting an implant, and this implant has to last for at least 75 to 80 years in that patient, because their survival is not short. They're going to live full term. So we have a situation where you put an implant and it lasts for that long in an eye which is, we don't know the end of the inflammation in these eyes. Nobody in the world can predict when the GIA inflammation will cease or will stop. So till now we have no such information available, because more than half the patients will persist with inflammation, with the chronic inflammation. So in these eyes, putting an implant, I would rather wait maybe for later time, good times, when we might have better technology, might have better implant material, better control of inflammation, like before the, some of these long-term or the sustained release implants came. It was very tough to treat them post-operatively. Now at least we have some choices of using some of those inserts in these eyes.
Yes, sir. Thank you, sir. I have seen cases. I've seen one patient who had cataract surgery done about 10 years back, and she came with severe phacodonesis, and it always, she looks scary. The lens looks like it's about to fall.
Yeah,
so
that's what happens, in uveitis, because the zonules might be weak, and there's so much happening. These are not normalized. So one should treat them with kid gloves, these need special care. It's a major challenge. Doing filtration surgery for glaucoma and cataract surgery. Whereas on the other hand, doing a partial aperture surgery, small gauge, is much better tolerated than the anterior segment surgeries.
You can remove the lens through the pars plana route, and it's
that is what some
of
of these patients, hypotenuse GIA patients, bilateral blind. I have done so many of those patients, partial lensectomy and vitrectomy, and depending on the status of the ciliary body, whether you have only a tractional detachment of the ciliary processes or ciliary body, or is it a ciliary body process atrophy, one would use a silicone oil. And, again, the issue with the cyclitic membrane, because they are very, very tough, they run circumferentially and over the ciliary processes. and they may extend into the peripheral over the pars plana area, and they are white, thick, solid, collagenous membranes. They go into the periphery of the retina. So there's no question of peeling. I think, Arshee, you mentioned somewhere peeling of these. There's no question of peeling these fibrous tissues, because in these eyes, if you caused a arterogenic retinal break, that retina is never going to attach again. So what we like to do is, we really don't deal with the pars plana cyclic membrane, but we like to cut these membranes with bimanual procedures. We like to cut them with scissors in between the ciliary processes, so that the traction that is exerted on the ciliary process is relieved, and you can remove this, or cut away or dissect away these cyclic membranes from the ciliary processes, so the aqueous excretion can restart, again coming into the intraocular compartment. So these are very, very tough surgical procedures, but I have had very gratifying results operating on small eyes. And I think several years ago, we reported our cases also that, small eyes, short eyes, 15, 16 millimeter hypotenuse eye, if you can make them ambulatory, it'll be great.
Gratifying.
Yeah, it'll be very gratifying for the surgeon, So these are the challenges of surgery in these patients.
Thank you so much, sir, for giving so many pearls week after week. It's really great listening to you. And JB sir is also there.
Yeah, JB, hi.
Good evening, sir.
So you would like to add any pearls on cataract surgery in uveitic eyes?
You're muted, JB. You're muted.
To agree with Professor Amod Gupta, I have seen several cases down the line that having very good IOL initially, and there's so much of capsular fibrosis, hypotony occurs. I always ask the people my VR surgeon straight away to go for lensectomy, vitrectomy, vitrectomy, and they do well. And the uveitis is also comes under control.
Yeah.
Another point I want to highlight is that choroidal neovascular membrane, what we are seeing much more than what we thought, and can be one of the important causes of the visual loss than recurrence of choroiditis. So I give home Amsler chart to all my choroiditis cases to see the metamorphosis or kind of scotoma if they detect it. And any kind of, sometimes you cannot explain the visual loss, better to do an OCT to see SSOCT or OCT to see the choroidal neovascular membrane, so that nowadays with the anti-VEGF injections and all, you can control that visual loss, probably that severe visual loss, central vision field loss can be avoided. That's, I wanted to be cautious about the choroidal neovascular membrane.
Yes. Yes, that's a very important complication of posterior uveitis. So thank you, Dr. Arshee. Thank you, Dr. Amod Gupta, sir. Thank you, Dr. JB, sir, for the wonderful session today. And over to Subhav and Shefali.
Thank you, everyone.
Thank you, ma'am. Before we conclude, we have two small announcements to make. First is the much awaited physical eye focus is back, and for a 360-degree ophthalmology coverage for the postgraduate students from February 26th to March 5 at New Delhi, and the registrations are open. The students can register at www.miraevents.com. And one more announcement is that we meet this Friday, that is December 30th, for anterior uveitis session by Dr. Somashila Murthy. Good night, everyone. Thank you.
Thank you.
Good night.
Thank you, sir.
Thank you, JB.
Thank you. Good night. Happy New Year, sir.
A very happy New Year to you all. And we are going to meet on Friday again.
Yeah,
Sure.
sure.
Before New Year.
Okay.
Thank you, everyone.
Bye-bye.
Thank you, everyone.
Thank you, everyone. Good night.